Hi, good afternoon, everyone. Thank you all so much for joining. This is the first of our 5 webinars on Safer Patient Flow Bundle. So we're going to make a start now. There's a few less people here than I thought would join us. So we're probably going to have a few late arrivals. Just a little bit of housekeeping. Can I ask that if you're not talking, can you keep yourself on mute? I'll keep an eye on that anyway if you forget. I'll also keep an eye on the chat. So if you've got any questions that you want to ask, if you could pop them in the chat box, then I'll pick them up. So the way these sessions will work, I'm going to hand over in a minute to a few of my colleagues, Pete, Richard and Jyothi, who are going to lead the first part of the session. So Pete's going to give a bit of a talk about how Safer started. If any of you have met Pete before, you would have probably heard his story already. But for those of you that haven't, you can get a little bit of a background into Safer. What we'll then do is we're going to have a little bit of a discussion with Pete sharing, talking to a couple of the ECIST clinical associates, trying to get their perspective as consultants about what is senior review, how do they do it, what are your options, what are the things that make it easier to do, what are some of the barriers that you might need to overcome and how to overcome them. We will have time at the end of the session to open it up for a question and answer session from everyone. And what we'll do at the end, we'll maybe just spend 5 or 10 minutes just getting some feedback and thoughts from you about if there's anything particular you would like from ECIST to help you deliver the bundle going forward. So I'll hand over to my colleague Pete now. Thank you all for joining, and I'll speak to you in about half an hour.
Great. Just give me a shout, Spencer. Can you see these slides?
Yeah, I can see it fine.
Great. Okay. So yeah, hello everybody. My name's Pete Gordon. I'm Head of Emergency Care Improvement with ECIST, the Emergency Care Improvement Support Team, and I'm delighted to be joined by my clinical colleagues, consultants, Richard Genever and Jyothi Nippani. So I'm going to spend about 5 minutes just talking a little bit about the genesis of the bundle. And today we're going to focus on one part of that, and it's really important. They're all important parts, but this is a really important part, and that's the daily senior review. But I'm just going to start off by just giving a word of warning is, whatever you try and do, don't try and performance manage the Safer Patient Flow Bundle. It wasn't created in a meeting room. In fact, the genesis of it was when I was working in an acute trust. I was visited by ECIST and by Dr. Ian Sturgess, who I found very inspiring at the time, and we were supported by ECIST, and we came up with this idea of a bundle. But key message there, don't try and performance manage it. It won't work. It's all about attitudes, behaviours and culture. And, if you get that bit right, your chances of success go up, exponentially. And, the most dangerous phrase in the language, this is a great quote by Grace Hopper. It's the one that the IHI used. The most dangerous phrase in the language is, we've always done it this way. And the doctors we're going to speak to afterwards, after I finish talking, are people who never say this word. And that's why they're great clinicians who deliver brilliant senior reviews. So where did it come from? Well, as I say, we were visited by ECIST and by Ian Sturgess, who's one of my great mentors with urgent emergency care. And my background is that many years ago, I was a critical care nurse, senior nurse for critical care, and someone visited my unit, and we had quite a number of ventilator-acquired infections. And this chap said, have you heard of the ventilator care bundle? And I said, no, I haven't. And he said, well, if you do these 5 things every day for people who are ventilated, whether that's via a tracheostomy or endotracheal tube, you elevate the bed to 45 degrees, you give great oral care, you protect them from DVT, you turn the sedation off briefly, give them a sedation holiday, the chances of a ventilator-acquired infections go down. And I said, oh, I think we do all these things. And then what I did is I reflected and I walked around the unit and I looked carefully at every single patient. And what I found is we didn't consistently do them. And when we did do them, the ventilator-acquired infections came down. And that's where sort of inspiration about creating a bundle came from. And the other really important point is healthcare is a complex and adaptive system. And you need to make the rules as simple as possible. If you create really complicated rules, which sometimes we see in the NHS, their chances of success are limited. So the bundle itself has 5 elements. I'm not going to go through all 5, And you know, when I was thinking when I sort of created it, I was thinking, how can we make them as simple as possible? And the first one is senior review. So thinking about those board and ward rounds. Just before I finish and start talking to our clinical colleagues, is, you know, what's the problem we're trying to solve? So this pictorial, this horizontal view of patients arriving by ambulance, going through the emergency department, acute assessment, and then into inpatient wards. When you really break that down and you think, where do patients wait the longest? And it tends to be at the latter part on the right hand side of the screen. And I created the bundle really to try and reduce unnecessary waiting and all the harm that's associated with that in particularly medical inpatient wards. So that's a very quick few slides from me. What I'm going to do now is stop sharing my screen. I'm going to go to Jyothi and Richard, and I'm going to just ask you a few questions. So I guess maybe we'll start with you first of all, Richard. And why is a daily senior review really important?
So I think a daily senior review does a few things really. It sets the tone for the day's work. It's a really important way of getting across what today's tasks are and today's decisions are. I think one of the things that senior input at the beginning of the day does is it gets away from that tendency for tests to be used as an alternative to decision making. So you can reduce the amount of things that are done to people that are potentially not helpful things by getting that decision early in the day. So yeah, I think it's definitely helps with clarity of decision making, setting the tone, and avoiding unhelpful things happening to patients.
Brilliant, thanks, Richard. Jyothi, anything to add?
I mean, everything that Richard said, and addition to that, I think if you concentrate on the word the senior, the hope is that with that senior and that experience, you actually get the best management decision for the patient. There is confidence in decision making, there is confidence in risk taking, there is appropriate delegation, not inappropriate delegation. And by the senior person being there, it's actually the ability to lead that team, develop that culture, exactly as you said, ABC. You know, how to do a job and how to make your team autonomous so that they can function even without you. It's all about teaching and training, giving them an opportunity to try and innovate, take risks, allow to fail, but all within a safe environment, build those relationships, build confidence, and creating an atmosphere where respectful challenge is normal practice so that you can actually challenge each other very well.
Brilliant, thanks both. I've just noticed that Ian Sturgess is on the call. So just as a heads up, Ian, you know I'll do this if you're on the call, is as we just go through, I'm going to just refer to you as well, Ian, having you on the call, that level of expertise as well. Okay, so next question. What does a good senior review look like? And maybe if we start with you first, Jyothi, then Richard, and then I'll ask Ian as well.
Okay, we are trying to get that ABC in practice here. So for me, a good senior review looks, the first thing is arrive on time, be a model to your entire team, include the entire MDT, ward clerks, everybody is important, and the entire team is important. Start with the board round, go through every patient. You need to have an EDD, a clinical criteria for, discharge for every patient. It's your thoughts being, told out and sort of expressed and being out there for everybody to listen, learn, and challenge. That's really important. And so once you go through every patient on a board round, then you actually choose which ones you want to see first. You prioritize which order you want to do. You don't need to see every patient, even though they're new patients. And I'll say this openly in this forum. This is how you create your teams, where you can trust your team's assessments to see new patients, where you don't have to see them all. So that's really important. You are the person who is the decision maker people come to. So delegating appropriately the whole ward work. At the end of that ward work, you have an action list of who is doing what, and very clearly identified so that there's no confusion. And once something is done, you actually tick off and say, yes, this action is done, so that everybody again knows that it's been done. Identifying what are the discharges for today, what are the discharges for tomorrow, and then having an escalation process, like, what is, if it doesn't happen within the team, how do you escalate it? If it happened, the next step is operational escalation. If you can't do it within that team, how do you escalate it to the operational team? And the trust improvement response to that as well. So there are stages of escalation, but all these we need to know. So that's a quick summary of how I would do it.
Brilliant. Thanks, Jyothi. What about you, Richard?
Yeah, so I think one of my thoughts is that I think the word ward round can be an unhelpful term because it for many of us, it paints a picture of a very traditional ward round where a trolley is wheeled very slowly and purposefully from one end of the ward to the other end, seeing every patient, giving them the same amount of time and that sort of thing. And one of the problems with that is A, it doesn't really address the needs of the people that you're seeing. The second thing is, if there's anybody who's thinking about trying to build in daily senior review pictures that model, it's impossible to deliver every day, to senior level. It just cannot be done. So I'd agree with what Jyothi had said, which is you need a much more intelligent approach to how you deploy your senior decision making. So I often talk about a thing called the head chef model. So if you're lucky enough to go to a nice restaurant, let's say it's one of Gordon Ramsay's restaurants, he isn't in the kitchen frying every single egg and buttering every single toast soldier to go out. But what he is doing is he is definitely aware of the quality of every boiled egg and soldiers that goes out of his kitchen. He's overseeing it all, and he is making sure that the team he's working with know what good quality food looks like. So in the case of a ward round, the senior person is there overseeing what's going on, making sure they know who is sick and also who needs difficult decisions to be made, and identifying those people and focusing their time on the things that only they can do, but allowing people to do the other stuff that they can do, to actually, to be able to push themselves to the limits of their abilities, and actually for people in training posts to take them just that little step beyond what was possible yesterday, to get them to do more things tomorrow. And that sort of approach, you're getting the senior involvement for every single person, and I think the huddle is the place to do that, as Jyothi said. But you're allowing other people to grow and develop and have more freedom. There's always got to be the ability for people to say, well, wait a minute, what I've discovered when I've gone out and seen this person doesn't match what we discussed in the huddle, and having the door open for that discussion is essential to make this work. But yeah, it's definitely not one person slavishly going around having the same conversation with everybody. It's being more focused, more intelligent, starting with the sick people, seeing people that might be able to go home that day as the priorities, and making sure we've got plans that we've got for everybody, that are specific plans that don't include things like social sort or discharge planning, specific, clear plans.
So no OT-PT.
Indeed.
Yeah, brilliant. Thanks both. Ian, are you there?
Yes, I'm here, Pete.
Hello, Ian. As soon as I spotted your name that I'd be bringing you into the conversation. So, you introduced me many years ago to many of these concepts and you've got international experience as well. You really have been to lots of places and seen lots of things. What does a good senior review look like to you?
Well, I like Richard's analogy with the head chef. I talk about it being the conductor of the orchestra. So it's having everybody on the same page. Everybody's clear about what the plan is. Everybody's clear about what needs to be done today and who's going to be doing it. And everybody knows that if something isn't going to happen, what the internal escalation process is, what the escalation to the ops management is, if the team can't resolve it. But also planning for tomorrow. So it's not just about doing today's work today, but it's making sure that you're clear about tomorrow. And the crucial thing about this is about flattening of hierarchy, that if anybody feels that things aren't going in the right direction, it's not slavishly following a single person's view of the plan, but somebody can stick their hand up and say, whoa, hold this person isn't quite going on as we expected. And then that may well be one of the patients you go out and review and go, okay, we need to change the plan. So that to me is the crucial thing. Everybody being on the same page for the plan, everybody knowing what actions need to be done and who needs to do them, and being clear about doing today's work today and then planning for tomorrow, but having that clear safety element of, hold on a minute, this isn't quite going in the direction that we wanted it to. We need to have a rapid review. So those are the things I'd say. Richard and Jyothi have covered it all in what they're saying. So yeah, that's what it is. That's what a senior review is. It's the conductor of the orchestra. Brilliant.
Thanks, Ian. So next question. So I think this is something people will be interested in is, can you maybe give some examples, some practical examples of where you've seen or you've experienced really good examples of a senior review from your own practice or experience? Sorry, Jyothi.
Okay, my own experience, yeah. I've seen lots of really good, fantastic board rounds and board rounds. Usually it happens that when there is a good system established, people arrive on time, and really arriving on time is very, very important to me, because everything gets pushed otherwise. And again, I've seen lots of mundane tasks which the junior doctors end up doing first thing in the morning, writing all the results which are already there on the computer on the notes again. I would eliminate all that stuff because it's all available. We should not spend our junior doctors' time writing stuff which is not necessary. The important highlighted ones we really need there. And the other thing which I have found really with some very good board rounds is, there are tasks and you delegate it appropriately. There are some very nutty tasks which are, very difficult referrals to difficult specialties or difficult people or outside organizations. I have seen that real good clinical leadership, they take those tasks themselves, so they delegate those to themselves. So if I was doing the board round, I'll take those because they're much easier for me to handle, to talk to other specialties or other clinical colleagues than delegate it to an FY1. So I would really, that's a really good example of appropriate delegation and the flattening of the hierarchy, where I'm taking some, some of the work as well. The other thing is approachability. I think if you know that what happens very often is you do the board run and you go, and people think that they can't disturb you until you come back next time. So if you say, look, I'm only going out somewhere, to see a patient and I'll be back, but you can call me if something happens meanwhile. If, you've got a result of an investigation back and you want to update the management and you want to discuss with me, hey, I'm there. Don't think you have to wait until the next day morning to discuss with me or the next board round. So this is something which happens very often. I see people are hesitant to call the consultants. So I would just, your phone number is there on the whiteboard saying, please call me, and making yourself really approachable and available is really, really important. And for every patient, really asking that question, what is it that's happening for this patient which can only be done in an acute bed? Why can't it be delivered elsewhere? That's really, the team need to know that this is an MOT. It is not a full servicing that we want to do. We can actually carry on with the rest of the management at home or in a different way. So we really need to get into that culture of that. Yeah, so I just think that these are some really important things that I think I have taken away from my seniors, that will help the team to empower the team to be making good decisions in a timely way.
Yeah, brilliant. Thanks. And Richard, any sort of examples that you could share with the people listening in?
Yeah, so I think one thing that's really helpful to do is to kind of have a refresh fairly regularly to make sure that everybody understands how things are going to work. So what I'm thinking of in particular is in huddles, it is very easy for it to turn into a bit of a chat or an MDT where problems are discussed in some depth. So I find that if every couple of weeks I say, by the way, just to let you know, if I think we're discussing something that probably needs discussion, but outside of this meeting, I will stop you. Don't be offended. And remembering to say that every so often, I think, means that when you do inevitably have to say, okay, yeah, let's discuss this after this, you've avoided somebody feeling like they've been thwarted in their prime. I think another really useful thing for a senior review is for that senior review to have a memory. So there's different ways that can happen. So it could be the same person doing the senior review every day. So have a sort of consultant of the week and they will remember what happened. Or it could just be an effective way of handover. So something that the person doing the review on a particular day knows what happened the day before. That's a really effective way of making sure that things don't keep being missed day after day after day, because it becomes excruciating to say for the third day in a row that something that was discussed that needed doing previously hasn't happened yet. So people very quickly get into the habit of trying to do things on the day. There's a couple of things that I've reflected on. So I mentioned clarity earlier, and clarity is absolutely essential. So you can't predict exactly what's going to happen, but what you can do is you can give very clear criteria of what would be okay and what wouldn't. And so one of the things I found is I have this habit of saying the word probably during huddles, and it's about the least helpful word that I can use. So I try to listen to myself as I'm talking and say, if I'm on the other side of this conversation, will what's being said be helpful? And so when I hear myself saying the word probably, I stop myself, re-say the sentence and say, if X, then Y, essentially. I know there'll be a lot of people who are skeptical about how effective all of this stuff is. And we actually did a little project where we had a ward. It was a medical ward, but it wasn't assigned to any particular team. So all the teams in the hospital had patients there, and you'd have 6, 7, 8 different teams visiting and seeing a few patients. And we introduced a huddle, and it was a geriatrician that would lead the huddle, and they discuss every patient, whether they were under a geriatrician or not. And within about 4 weeks, the average length of stay for that ward had dropped from 8 days down to 5, purely by introducing that. And it really is that idea of somebody caring what today's decisions are and making sure that they're set out and clear.
Brilliant.
Can I just quickly add one more thing? What I've seen some people do, and which is really very helpful for the entire team, is they make sure that the entire team is leaving together at the end of the day, so that one person or a few members are not left with lots of tasks. So everyone leaves the ward together, and that's a fantastic way of having a supportive culture within the team.
Yeah, no, that's definitely, teamwork's crucial, and that's a great example, Richard, of how the positive outcomes you get from a really effective senior review. Before I ask you, both of you and Ian, around some extra top tips for senior review, and I'll ask you some other questions, is what about an afternoon huddle on the ward? So there's the bundle sort of says daily senior review, effective senior review before midday, but how important is a huddle in the afternoon? Jyothi?
Okay, very, very important. So you've made a list of actions during the day, and it's so important to know if something hasn't happened, and that is where your escalation, you start picking up why things haven't happened, and where do you escalate it to, and how do you plan for the next day. So there's absolutely, then second, actually Richard said about continuous review or number of reviews throughout the day. That's even better than an afternoon review. But if you don't have time for that, at least an afternoon review is absolutely important to answer that particular question.
Brilliant, thanks. Richard?
Yeah, so I would recommend trying to have, certainly for huddles, one huddle for the ward, rather than, if there's a number of teams visiting, trying to build a separate huddle for each of them. I think particularly if it's a ward that specialises in one particular condition, I would hope that you could have enough trust in each other's decisions that somebody else could sort of meaningfully lead a huddle for a different person's patients. So in our ward, we don't actually take any notice of which consultant somebody is under when we're doing a ward visit. We see the people that need to see a consultant and don't see the people that don't need to see a consultant, and so I'm sort of completely unaware of which initials are metaphorically above the bed. Other things that are useful, I think ward rounds are best when they are quick. That may be a controversial thing to say, but actually you need to leave enough time for the doing part of the day. And so if you are still going around the patients at 1 p.m. or late, having started in the morning, then for a start, your decisions are going to be getting worse and worse and worse rapidly. And there is good evidence to support the idea of decision fatigue. So you move into just holding pattern type decisions. But also you're leaving yourself and the rest of the team next to no time to actually get the things done that are going to help people. So actually there is some real benefit to the patients in a certain amount of brevity. And anything else? So I think and I think the thing to remember is you're not necessarily making the decision, you're just identifying the decision to be made. And that's why potentially you can make a decision on almost any patient if you've got the experience. I did a ward round just the other day when I set some criteria for somebody to go home. Said they could go home if they remain off oxygen at noon, they're eating and drinking, and they're up and about. And then about 40 minutes later, the trainee that was going around with me said, "Oh, by the way, their early warning score is now 13." And I thought, momentarily, oh gosh, I feel a bit bad about that. And then I reflected and I thought, actually, no, I couldn't have spotted that, but the process worked. The early warning score had gone up. The person that I was going around with recognised that this was a problem. They reflected that back to me, and we adjusted the plan. They had a quick review, and they stayed in, which is the right thing to do. So, yeah, that hierarchy thing is really important. The ability for people to just flag up this isn't following the script that we'd sort of discussed. Just recognising that is enough to make a difference.
Yeah, brilliant. Thanks both. I'm just going to go slightly off piece now. There'll be a number of people with nursing backgrounds like myself here, and I remember Dr. Gordon Caldwell, who now works in Scotland, did some great work when he's working in Worthing on ward round checklists, and part of his data collection was the amount of percentage, the amount of time nurses could join ward rounds. And so it's a real issue with low staffing levels, multiple priorities for nurses. So have you got any sort of tips for the people who are listening around? So these days it's difficult for a nurse to join a whole ward round. I just wondered if you had any tips to, sometimes there can be a slight breakdown in communication. The medical team have gone round, and if the nursing team, don't really aren't fed back the plan, it can lead to sort of gaps and delays. I just wondered if you had any ideas around that.
Yeah, so I think it's really useful to have the opportunity to have that sort of handover and discussion. I don't think it is necessary or realistic to have a nurse present for every moment of the ward round. And I feel that if I was to insist on that, I think it would actually, do an awful lot of damage. It would undermine the sense of, what my perceived value of the nurse's other roles is. So. But what I think works just as well, actually, is to have that constant kind of just contact, touching base every 2 or 3 patients, just to make sure that we're handing over small amounts of information. If there's something that's time critical, handing it over there and then. So, for instance, if there's a new drug that we've started, an antibiotic, say, it would be pointless waiting till the end of the round to hand that over. So seeking out the person to hand over to. But apart from that, making sure there is that constant, a bit like, you've got a bird that's flying off and will return to the nest frequently with, with something for the fledglings. And it's that kind of, we'll both separate, we'll do what we have to do, and we'll return and we'll reconnect and just make sure there's constant handover. And it works both ways, of course. So that person whose score was 13 were highlighted to us because the nurse that was looking after them did the observations, quite rightly recognised that was a problem, and came to tell us. So I don't think it needs to be fixed going around together, but there needs to be recognition that making contact frequently is going to be helpful.
Yeah, agree about the communication. Jyothi?
Yes, I'm one of those who comes very, very early to the hospital, and I do catch
That's a surprise.
the nurses handover, and they are really very, very informative. And I always wondered why we actually don't have the nurses handover as part of the whole ward round, because it's a fantastic handover. And personally, I've being an obstetrician and gynecologist, I have really grown up to depend more on what the nurses tell me about the patient. I value their opinion on the patient much, much more than what some of my junior doctors sometimes do, because the junior doctors are there only for a short time, whereas the nurses are doing 24-hour cover. They know much more about how the patient moves, how they go to the toilet, who's come to visit them. Lots more information you get from the nurses. So I do absolutely value their opinion, and and if for no other reason, just to make aware of what is the action following our ward round, they need to be there. And when I first started my job as an associate medical director for emergency division, one of the biggest things I found in the medical wards was multiple ward rounds, taking away the nurses every time for every ward round. So this is where the whole concept of consultant of the week emerged, where there's only one ward round for the entire ward for the entire week. That way, it leaves everyone is able to participate in one board round, and it leaves the rest of the day for people to get on with the work. Otherwise, they're interrupted multiple times all the times. And so this is how we had to change the job plans for the entire medical division to make it consultant of the week model. And that facilitates the sort of board round which Richard is talking about, where you don't care whose name is at the end of the bed. You just do for the whole ward, and everything is sorted first thing in the morning. Plans are made, and you review the plans as you go along the rest of the day.
Brilliant. Thanks both. I'm going to come to top tips in a second, just to give Ian a heads up. I'm going to come to start with Ian on that. But I just wanted to briefly mention, just bring in criteria to reside. So as for people listening in, I'm sure a lot of people will know about it. So some people call it reason to reside, came with a discharge policy. But it was just some, so we know in some organisations it's not done at the board rounds or ward rounds, but just top tips. Where should it be done, or when?
I think board rounds are a good place to do it. So Ian, who's on the call, helped to develop the News 2 decision support tool, which takes the principles of criteria to reside and helped us to turn it into a set of questions that you can follow to decide who really needs that inpatient care. Because ultimately there are only two real reasons to be in an acute hospital. There is being sick enough to need that level of supervision, you can't be anywhere else, and then there's needing treatment that can only be delivered today in an acute hospital. Everything else is really a sign of the system as a whole, and maybe not being able to deal with certain things. And so criteria to reside essentially acknowledged those two principles, and the News 2 decision support tool does the same thing. So before I do a huddle in the morning, I look at the early warning scores of every patient on the ward. Now, I know that alone will not tell me who is doing well and who's not, but it'll give me an idea of the people who are struggling. So I'll go into the huddle armed with that information. The other thing I think is really helpful to do is just to walk down the ward and just eyeball everybody, and just you'll get another level of insight into who is struggling at that point, and then that can really inform the rest of the huddle. If your early warning score isn't high, then it sort of takes you through a series of other things. Are you on oxygen? You can't be weaned off. Do you require treatment that you can only receive in hospital? It just leads you through a series of questions that you can ask out loud at the huddle, really. If you find that the plan is continue, then that's the time to say, okay, let's just hang on a second. Let's just check the reasons this person needs to be in hospital. And often those reasons are not strong reasons. And we know that people who aren't specifically benefiting from being in hospital, will on average be harmed by it, because if your level of benefit is 0 and your level of harm is 0.1% per patient, there's still a net harm in that category. So you've got to really justify keeping people in hospital. I've rambled on a bit there, but I'll hand over to Jyothi.
Jyothi, anything to add? We know you're, as the National Reducing in Hospital Length of Stay lead, you're a big supporter of criteria to reside. So is anything to add to Richard's reply?
Everything that Richard said, and asking that question for every patient: what is happening to this patient on, which can only be done from an acute hospital? If they're on IV, can we change them to oral? If they're, can we have another way of administration? Can the patient self-administer at home? Not meeting the criteria to reside doesn't mean that the patient is well and we are pushing the patient out. How can we continue some of the management at home or in other places, or in an alternative way? So that is the thinking changing. So we're not looking for, as I said, full servicing. We're looking for a quick MOT and home and continuing the patient's care at home. And that's really important. And that's where the challenge is really important. The team should be able to challenge, actually, can we not do that elsewhere? Can we not bring them to an SDEC? These sorts of things, we should be able to challenge each other very well on the board round.
Brilliant. Sorry, Richard.
I was just going to say, I think Jyothi raises an important point, actually, because I think there's a lot of nervousness about the criteria to reside. And people, I think, wrongly feel that if you say that somebody doesn't meet the criteria to reside, then a modern day equivalent of the child catcher from Chitty Chitty Bang Bang will come along with a net and take them away and put them somewhere, and that nobody will ever think about them again. Actually, it's not that at all. The decision to keep people in hospital remains a clinical decision, but being focused about who really needs that and who might be better off receiving the care elsewhere is actually better for the patients. A side effect of it is that you end up with fewer people in hospital that don't need to be, but actually it's all about where would be the best environment for this person to receive what they need right now.
Brilliant. Thanks both. I'm just going to go to Ian Sturgess now to get some top tips, but just so you got a bit of time to think, Richard and Jyothi, then I'm going to come back to you. We know there's lots of really useful resources out there. You've mentioned some of them, Richard. So just going to come back to you after we've got some top tips from Ian about sharing resources that people can access after this talk. Ian, you trained me many years ago on all things urgent and emergency care back in the 19th century. What are your top tips? I'm joking. What are your top tips for the people who have joined the webinar around senior review?
Okay, thanks, Pete, and thanks for aging me. I think the crucial thing is we talk about attitudes, behaviour and culture, but we know we can change structures, we know we can change processes, and we know the crucial thing to change is patterns, and attitudes, behaviour and culture are part of patterns. But the other crucial thing is about leadership. And what senior review means is about you're leading the team, but in a non-hierarchical way with a flattened hierarchy, right? So it's creating that expectation of what needs to be done today, creating that complete intolerance of unnecessary waiting for patients within the team. So, that people are saying, right, what is the next thing we're doing? How are we adding the value to the patient? I do want to come back to the criteria to reside. It is a checklist. It's not a decision substitute tool for clinical decision making. It's just a tool to help you go through. Well, they don't meet these, they don't meet that. So why do we really need to keep this person in? Oh, yeah, they've had a subarachnoid hemorrhage, although their blood pressure's fine and whatever, and they haven't had their aneurysm clipped. Yeah, they've got to stay in hospital. So let's be very clear about the criteria to reside. They do not replace clinical decision making. They're there as a checklist for people to go through and to help them to ask the question, which is another crucial key tip, is why not home? Why not today? Why can't we do this out of hospital? And Richard and Jyothi have both said this, absolutely crucial. Every day, every morning and every afternoon, and I'm a geriatrician by trade, so I'll be slightly coloured by the groups of patients that I used to look after. Every hour or day that somebody stays in hospital who's living with frailty, who didn't need to be there, exposes that person to the risk of avoidable hospital-acquired functional decline, which pre-COVID was the biggest unrecognised pandemic, and I mean pandemic, across the world. 40% of people aged 75 and over suffer avoidable hospital-acquired functional decline if they get admitted to hospital, and that's predominantly due to unnecessary waiting and sleep deprivation. So let's get this lens of focus on a complete intolerance of unnecessary waiting in patients' journeys, because I don't know any patient who gets quicker, who gets better faster, the longer you delay appropriate interventions. Because if somebody can tell me an acute condition that gets better faster, the longer you delay appropriate interventions, please let me know, because I've never found one.
And I also remember you telling me there was no randomised controlled trial for a hospital bed many years ago.
There isn't. Yeah. There is no randomised controlled trial for the hospital bed. It's the things that we should be doing to patients, but they need to be done in a timely manner that meets the recovery rate of that individual patient.
Yeah, brilliant. Thanks, Ian. Just going to, before we hand back to Spencer, who's going to do a little poll in the last 3 minutes, just there are resources out there that people can access, and I know in ECIST we're very familiar with them, but maybe we could run through just a few things that, so we've got there's some new publications, we put stuff on our future site. Maybe if we go to you first, Jyothi, sort of useful resources that people can access, read and use.
I have a list here with me, but I'm sure we can produce a list of places where, you know, there's good information. As I said, the Royal College has just, Royal College of Physicians has just released the modern ward rounds guidance, which is really excellent. And yeah, there are lots of useful ECIST resources as well on the NHS Futures platform. I'll pass it on to Richard, actually.
I'll just jump in on the modern ward rounds guidance. So we're working quite closely with the RCP, running a modern ward rounds collaborative. But if you Google modern ward rounds, you find it online. There's a self-assessment in the back of the document. And so all the systems we're helping with ward rounds at the moment, we encourage them to fill a self-assessment out. And there's an Excel document on our NHS Future site. It takes a team 10 minutes to fill it out, and it will show you where your opportunities for improvement are. So that's a very practical thing every team on here could do. I think Ian just wants to jump in before we go to Richard.
Yeah, I just want to reflect on the modern ward round. I mean, I agree with Richard about having slick ward rounds, but wherever possible, do a one-stop ward round where the tasks that can be done on the ward round get completed on the ward round, rather than listing a long list of jobs, because writing a long list of jobs that get done after the ward round is batch processing, whilst a one-stop ward round is single piece flow, which is the most efficient way of running processes.
Yeah, thanks, Ian. You can tell Ian is lean trained there. So Richard, just before we hand over to Spencer, I mean, some of the other resources you've been heavily involved in developing, for example, which isn't maybe to do with a senior review, but things like criteria to admit and things like that. Where can people access these resources?
Yeah, so that you're quite right. So I've been involved along with a number of other ECIST colleagues developing a tool called Criteria to Admit. It comes from the same principles as the criteria to reside. So at the point that a decision has been made to admit somebody, and that could be from ED, or it could be an admissions unit, or somebody's been admitted straight to a ward. If your decision is to admit that person, it's just a way of sense checking it, starting with the early warning score, then looking at the underlying pathology. So is it something that is serious enough that there are imminent risk of life-threatening deterioration? With both these tools, there is a kind of like a stop moment where there's a question: would you admit this person if you saw them in a non-acute setting? So if you saw them in a GP surgery or a clinic, would you be making the same decision? That's a really useful one when you're looking at people that are staying in hospital for a test. You may be worried that this person's got a serious underlying condition like cancer, but would we actually admit this person to do this test? The answer is nearly always no. So it's a really helpful test. So, and if somebody may be managed better on a non-admitted pathway, for instance, through SDEC or something like that, then there are other questions that just help to make that happen more smoothly. All of this stuff's going to be hosted on the NHS Futures website. We've recorded a video of a bit about how the process works and how to use it. And also there is an audit tool that you can use as well. And we've recorded a 4-minute video that explains how to use the audit tool. We'd recommend doing it before you implement the change, because invariably it shows up. There are a lot of people in our beds that, had we applied this approach, probably wouldn't have needed to be admitted, and it could be a really powerful thing to have that information before you set off. I think in addition to C2A, also there's a whole load of podcasts that are really worth looking at if you're wanting inspiration. There is the ECIST blog as well that lots of people in various roles, clinical and non-clinical roles, contribute. And again, I think it's good to dip into these places from time to time to really kind of get your creative juices going. And I'm going to recommend one book as well, which it's a book called Turn the Ship Around by a guy called David Marquet. Many of you will be familiar with this, but he is an exponent of something called intent-based leadership, essentially encouraging people to say what they intend to do rather than coming to you and asking to be told what to do. And following that model really encourages people to grow and to become leaders themselves. So yeah, lots of sources of practical and inspirational material on the NHS Futures website in particular.
Brilliant. Thanks, Richard. Thanks, Jyothi, and thanks, Ian. Apologies for springing that on you, but whilst you're there, we'll always pick your brains, Ian. And just what I would say before I hand back over to Spencer, if you're not a member of our NHS Futures site, if you put your email in the chat box, we can just invite you in. And everything that we've talked about here is readily available. So thanks, everybody. I'm going to hand back to you, Spencer.
Thanks, Pete. And again, thanks to our medics for their thoughts and Ian stepping in a completely unplanned way. So that was really, really helpful. There's just a couple of questions that came through in the chat. So one of them, Richard, kind of carries on from what you were just talking about whether or not there's been much pushback about using the reason for admission. I suppose that's probably both in terms of from families themselves, if you were using it kind of maybe a bit more, it's a blunt tool, but I suppose also from the other specialties and the other consultants where you're maybe having a conversation to say, well, you know, we're not quite sure that patient did need to be admitted.
Yeah, so there's lots of questions in there actually. So I think it's up to clinicians to communicate about the balance of risks and benefits of hospital admission. And there's no reason why patients and families should necessarily be expected to kind of understand that from the outset. So I think it's up to us to kind of communicate that, and it's not always an easy thing to get across. And there will be times, so for instance, if you've got a very frail older person, it's 3 o'clock in the morning, they live on their own, you know, whether their specific medical condition requires admission or not, it might not be appropriate to discharge that person at that time. As it happens, I brought my own dad home from ED at 1 o'clock in the morning a couple of weeks ago, and it was absolutely the right thing to do. But he had a consultant geriatrician to keep an eye on how things are going, so not everybody has that. So in terms of individuals, so I would say that these tools, things like the criteria to admit tool, are most potent when somebody is kind of asking you the question, but that is the most challenging way to do it. And I think I would sacrifice a little bit of potency of the tool for more people say, yes, let's give it a try. So I tried the News 2 decision support tool where I asked a colleague to just kind of drop in on me one day and just challenge me with the tool, and it definitely made a difference. And I think of myself as somebody, you know, because the immediate response most people have is, yeah, we do this anyway. And I think of myself as somebody who tries to do this, but my goodness, if somebody else comes along and asks you the questions, it really does push it up another level, but it's rock hard. Another thing I noticed in the chat box popping in was about weekends, in terms of sort of pushback. I thought I might just sort of give some thoughts on that. And I think all of this stuff about sound senior review is, I think, ask yourself, what are we doing now and what could we do? So if you're not doing it at all, what would it be like if you did it a couple of days a week? If you're already doing it 2 or 3 days a week, why don't we try and get to 5 days a week? And if you're doing it 5 days a week, what would it take to push it up to 6 or 7 days a week? So I think it's important not to be didactic about these things, to say it's all or nothing. It's what can you do that will build on what's currently being done in your place. And if you can do it that way, I think you can take people along with you rather than people feeling that they're being pushed into something that they just cannot do right now.
That's really helpful. Thank you, Richard. Just adding just really quickly onto that, the pushback about doing something like the criteria to admission tool or some kind of review like that. There's been a lot of talk about flattening hierarchy, and I suppose that some of that human barriers and defensiveness is being challenged. So there's something to think about around the consistency to which you do something like this. If you apply something really randomly, really sporadically, it can feel quite personal. People can feel like you're picking on them, and why me? Why today? What are you thinking about? If you do something, if you build it into a planned review, maybe it's part of your weekly review of long-staying patients. If you build it to be a standardized way of working, it begins to break down those barriers, and that should make people a bit more open and make those conversations a little bit less uncomfortable. They were the only two questions, so I'm just going to quickly ask. I did put it in the chat. Is there any other questions from anyone while we've got so much clinical expertise on the line? You pop your hands up or jump in, whatever's easiest for you. Ian's got a question. Go ahead, Ian.
No, it's not a question. It's just actually a support of the criteria to admit and criteria to reside. There's a tool out there called the Appropriateness Evaluation Protocol that was first created in the States in the 1990s and Europeanized in the late 1990s and Antipodeanized in the early 2000s. It has two groups of criteria. There's the admission criteria, and there's, depending on which version you use, there's 15 to 20 admission criteria. And then on the day of care criteria, so when you do the review, there are something like 35 criteria. It has a very extensive evidence base internationally, multiple publications around it. You get similar sorts of results. Between 10 and 14% of patients don't meet the criteria to admit. Doesn't mean they don't need to be admitted. They just didn't meet the criteria to admit, so they should ask you the questions. Another 5 to 8% are admitted only having intravenous therapy. So you have to ask the question, why can't we do this as a day case or something like that, or at home or whatever? And on the day of care criteria, what you see internationally is between 35 and 45% of patients not meeting the day of care criteria. And so ask the question, where else could you be caring for this person? So please, everybody, if people are criticising the criteria to admit and the criteria to reside, there is actually a 30-year published evidence base for using these tools to ask those questions. The problem with the AEP is you can't use it every single day because there are far too many criteria. So what the criteria to admit are and the criteria to reside is just a very simple checklist of things that will cover most scenarios. So I'm a huge fan of both the criteria to admit and the criteria to reside, but as using them as a checklist. That's what I wanted to say.
Thank you, and that's really helpful. Jyothi, you've got something to add?
Yeah, something to add on criteria to admit. It's really a tool to change the thinking. So it's not a directive. It is not something that's mandated. It's not something that is, going to have data collection or anything behind it. I really want to emphasize that it's simply an improvement tool for clinicians. And what it actually identifies is the gap. The audit tool is basically to identify what are the gaps in your services which will facilitate a non-admission. So if you had those services, you probably wouldn't have admitted those patients. So it's really an improvement tool to identify which services you need to focus on and build so that you don't need to admit the patient for that sake. So I really want to focus on the fact that it's an improvement tool. Yeah.
Thanks, Jyothi. Okay, everyone. So it is nearly 5 o'clock on my laptop, and if you're anything like me, there's tons of stuff just bouncing around your head. So just to close, I want to say thank you to Pete for sharing the session and asking the questions. That was really helpful. Well, I've got a small person that joined me. I want to say thank you to Richard, Jyothi and Ian for answering the questions and giving your very well-reasoned and knowledgeable input to it. And just a final point from me is, after this session, what we'll do is we'll send an email around to everyone that's joined. We'll give you the links to the ECIST NHS Futures area. So there's loads of tools, videos, everything on there. We'll send you a link to the AEP, which Ian has just talked about, just so if you're interested there. We'll send a bit more information around the criteria to admit modern ward rounds. We'll send a video of the session, so if you want to share it with anyone that wasn't able to join. And we'll also just include a small poll. So any of you that's worked with ECIST in the past knows that we genuinely want to help and we are quite practical. So if there's anything that you would particularly like around how to implement the S in your organisation, just drop it in the poll. If we've got something ready-made, we'll ping it over to you. If not, we can look at developing something further. So other than that, thank you all for your time. I hope you've enjoyed this last hour, and I look forward to seeing some of you, if not all of you, again next Wednesday when we talk about the A, the bundle.